Across clinical settings and public health campaigns, weight loss is most commonly promoted as a way to reduce the risk of heart disease, type 2 diabetes, and hypertension. While these are valid and critical goals, this narrow focus has created a dangerous blind spot. Cancer prevention is consistently overlooked in obesity treatment programs. This omission has serious consequences, as mounting scientific evidence confirms that obesity is not just a metabolic issue, it is a significant carcinogenic force. Ignoring this link limits the effectiveness of obesity care and leaves patients vulnerable to some of the deadliest, yet preventable, cancers. Obesity is now known to increase the risk of at least 13 different cancers, including some of the most aggressive and fatal: colorectal, liver, pancreas, endometrial, esophageal adenocarcinoma, kidney, and postmenopausal breast cancer, among others. The mechanisms are well documented. Excess adiposity leads to chronic inflammation, insulin resistance, elevated levels of insulin-like growth factor 1, IGF-1, and increased production of estrogen in fat tissue, all of which promote tumor initiation, progression, and metastasis. Yet, despite this well-established biology, weight loss interventions rarely frame cancer prevention as a primary outcome or motivational goal. This absence of cancer from obesity discussions isn't just a missed opportunity, it's a public health failure. Most patients in weight management programs are never told that their excess weight could fuel the growth of cancer cells, or that weight loss could meaningfully reduce their future cancer risk. Instead, the focus is often limited to improving blood sugar, lowering cholesterol, or reducing cardiovascular risk scores. These goals, while important, reinforce a medical silo that separates metabolic health from oncology, despite their biological overlap. Part of the problem lies in how healthcare systems have evolved. Obesity treatment is typically managed by endocrinologists or primary care providers, while cancer risk assessment and prevention is handled by oncologists or screening programs. These disciplines rarely intersect in meaningful ways, and as a result, the cancer-related benefits of weight reduction are rarely integrated into treatment guidelines or patient education materials. There is also a troubling absence of cancer outcome tracking in most clinical obesity trials. Few studies look beyond diabetes remission or cardiovascular biomarkers to evaluate how sustained weight loss affects long-term cancer incidence. This fragmented approach is compounded by insurance and policy structures that do not prioritize prevention. In many health systems, weight loss interventions are only reimbursed if the patient already has diabetes, hypertension, or sleep apnea, not if they are simply at high risk for cancer. This reactive model delays intervention until damage is already underway, missing a window in which weight loss could have prevented cancer from ever taking root. For women in particular, this blind spot is especially dangerous. Postmenopausal obesity significantly raises the risk of breast and endometrial cancers, yet few women are told that maintaining a healthy weight is one of the most effective ways to prevent these diseases. Hormone therapy, breast density, and family history are emphasized in cancer prevention conversations, but rarely is body fat treated as a modifiable risk factor deserving equal weight. This is not just an oversight. It is a systemic devaluation of one of the most controllable and potent levers of cancer risk reduction. Men are also affected. Obesity is linked to more aggressive forms of prostate cancer, as well as colorectal and liver cancer, all of which carry high mortality rates. Yet men are often even less likely than women to seek or be offered weight management support unless they show overt signs of metabolic disease. Cancer risk is rarely used as a motivator in male patients, despite its potential to resonate more powerfully than abstract cardiovascular numbers. The failure to frame obesity as a cancer risk is also reflected in public messaging. Weight loss is marketed primarily as a path to aesthetic improvement or energy enhancement, not as a way to avoid a deadly disease. Even when governments do promote cancer prevention, the focus is often on smoking, alcohol, and infection control, e.g., HPV vaccination, hepatitis B, while obesity is treated as a secondary concern. This leaves the public dangerously uninformed about one of the most modifiable cancer risk factors. There is no doubt that weight loss is difficult. It requires sustained behavioral change, structural support, access to healthy food, physical activity, and sometimes medical or surgical interventions. But patients are more likely to commit to these changes when the stakes are clearly communicated. Framing weight management as a core cancer prevention strategy can give people an additional, life-saving reason to act, one that goes far beyond controlling blood sugar or fitting into smaller clothes. It is time for a paradigm shift. Cancer prevention must be integrated into every obesity treatment program, from counseling and nutrition plans to pharmaceutical and surgical interventions. Providers should be trained to explain the obesity cancer link with the same clarity they use to discuss diabetes or hypertension. National guidelines should include cancer risk reduction as a formal goal of weight loss efforts. Public health campaigns should position obesity as not just a metabolic condition, but a cancer-promoting state, reversible but dangerous if left unchecked. If we continue to treat obesity without acknowledging its cancerous consequences, we will lose a critical opportunity to save lives. Weight loss is not just about numbers on a scale. It is about stopping disease before it starts, and that includes cancer. Until obesity care reflects this truth, we are not doing enough.